Hello, everybody, and welcome to the second session of Eliminating Hepatitis B from Day One, the Power of Hepatitis B Birth Dose Vaccination. My name is Lindsay Heber, and I'm the Deputy Director for the Coalition for Global Hepatitis Elimination at the Task Force for Global Health, and we're so glad you joined us today. Yesterday in part one, we heard from clinicians in New York City and Minnesota and public health officials on their experiences in ensuring hepatitis B birth dose. And today we'll hear from additional experts in Texas, Kentucky, and Chicago. So just to start with a little bit of housekeeping, if you have any questions, we ask you to submit them to the Q&A function in Zoom. We'll be recording today's session along with yesterday's and posting it to the Coalition for Global Hepatitis Elimination's website, globalhep.org, along with all the slide presentations. And if you're interested in more webinars like this or additional resources, we encourage you to sign up for the Coalition newsletter. Here is a QR code where you can access the webpage where today's materials will be posted. I'd like to introduce my colleague, Lisa Jack Carroll, who's a consultant with the Task Force for Global Health and the Coalition for Global Hepatitis Elimination. Lisa was previously CDC's Perinatal Prevention Program Coordinator, and we're really glad she'll be moderating today's webinar.
Thanks so much, Lindsay. I just wanted to give a brief overview of our agenda for today. I have a handful of slides just to sort of set the stage on the hepatitis B birth dose in the United States. Dr. Ward did present on this in a little bit more detail during yesterday's session. So if you haven't had a chance to watch that one, I encourage you to go back and check that recording. But we have Melissa DeHaan from Texas, Dr. Stephanie Deal calling in from Baylor College of Medicine, Ms. Roberta Butler from Kentucky's Department for Public Health, and Dr. Malika Shah with Northwestern Memorial Hospital. And we will try to have time at the end for questions and answers. So please do go ahead and put those in the Q&A chat and we'll start taking a look at them. So hepatitis B virus, just a little bit of background. This is a virus that affects the liver and it can persist as chronic infection and can progress to severe liver disease and can cause liver cancer. It is one of the most prevalent cancers, and it's the third leading cause of death globally, cancer causing death globally. About 250 million people in the world are infected with hepatitis B, and the highest burden is found in Asia and Africa. In the US right now, we have about 640,000 adults living with hepatitis B. And again, many of those adults were born in Asia or Africa. Next slide, please. So there's a handful of ways that we can prevent mother-to-child transmission of HBV. The first way that we do that is by identifying HBsAg positive pregnant women through routine pregnancy testing or testing at the time of delivery. Ideally, this is done during pregnancy because women who have high HBV DNA levels can also receive antiviral therapy during pregnancy to try to reduce the risk of mom transmitting the virus to her newborn. And then for all of those newborns that are born to HBsAg positive pregnant mothers, they should receive post-exposure prophylaxis as soon as possible after at the time of birth, after birth, and that includes HBIG or the hepatitis B immune globulin and a dose of hepatitis B vaccine. And those interventions can prevent about 94% of infections. And then all infants should receive a complete hepatitis B vaccine series. So not just babies born to positive moms, but all babies. And then the other really important thing that we're talking about today is the universal birth dose of hepatitis B vaccine, which is recommended for all newborns within 24 hours of birth. The sooner the better. And that serves as a safety net for any infants that were missed, that are born to positive moms or have household contacts that are positive. And the next slide, please. So again, why is the universal birth dose so important? in the United States and globally. There was a 2023 study that found that up to 500,000 pregnant women who gave birth each year in the US were not tested for their HBsAg status. So that's a very big risk. The perinatal hepatitis B prevention program at CDC only identifies about half of the expected births to HBsAg positive women each year for case management. And to sort of quantify those numbers, over the last 15 years, CDC estimated there were between 24 to 26,000 expected births each year, but only between 11 and 12,000 were identified for case management. We also know that a birth dose of hepatitis B vaccine alone is 75% effective at preventing mom to baby transmission. And also there can be household transmission of HBV since it is highly infectious. So the birth dose can protect babies who have HBV infected household contacts, as well as babies that are born to positive moms that maybe we didn't know her status at the time of delivery. And the next slide, please. And this is the current state of hepatitis B birth dose coverage in the United States. From 2011 to 2021, you can see we peaked in 2019 at 77%, and then the most recent year of data is from 2021 at 76%. So still some work to do there. We would love to meet that WHO 2030 target of 90%. Next slide. And now I'm going to turn it over to Melissa DeHaan. She is the Perinatal Hepatitis B Prevention Program Coordinator for Texas. And we look forward to hearing from her. Melissa?
Thanks, Lisa. Good morning from Austin, Texas. Thanks for inviting the Texas Perinatal Hepatitis B Prevention Program to participate in this webinar. My name is Melissa DeHaan, and I work for the Texas Department of State Health Services as the program coordinator for the state. I'm going to mainly discuss our program's educational efforts to prevent mother-to-child hepatitis B transmission, as well as our promotional efforts on the universal birth dose. So just real quick, I think we've gotten the history of the overall perinatal hepatitis B prevention program, but in Texas, we started our programs in Harris, Tarrant, and Dallas counties, and two cities, San Antonio and Houston, in 1991. And then in 1999, our governor, George W., signed legislation requiring hepatitis B screening for all pregnant women at first prenatal appointment and at delivery. And then by 2001, the Texas Department of State Health Services had expanded programs to cover the entire state. Next slide, please. So just in general, Texas is a big state, and you all are aware of that, I'm sure. We have a population of over 29 million, with 6.2 million being women of childbearing age. We have some very large metroplex areas like Houston and the Dallas-Fort Worth area, with over 15 million people combined in those areas, plus San Antonio, Austin, El Paso, adding another 6 million. That leaves about 8 million people spread out over a very large physical space. And some areas with our sparse populations and large spaces have very limited resources and knowledge about hepatitis B and then how to handle pregnant women with hepatitis B. Texas shares long borders, and a lot of them, with neighboring states and Mexico. Women in the program can be living in one state and getting prenatal care in another, which requires a lot of close collaboration with neighbors. And we have a very diverse ethnic population, with a majority of our foreign-born residents coming from Latin American countries and 24% coming from Asian countries. Next slide, please. So how do we staff this state with its various areas of density and ethnic composition and service availabilities? So as you can see on this map, we have 8 public health regions that are managed by 5 Department of State Health Services regional coordinators, all of whom are nurses. And here you can see we've got 1, 9, and 10 clustered together, and that's West Texas Panhandle. 2, 3, 7 is our Dallas, Fort Worth, and Central Texas areas. 4, 5, 6 covers the eastern part of the state. Region 8 is San Antonio and surrounding areas, and then Region 11 is South Texas. In addition, we have 46 contracted local health districts within these public health regions that are grantees and have staff working cases as well. And then Houston and San Antonio are individual grantees with the Centers for Disease Control for their programs, through their immunization programs. Next slide, please. Because of our state's large layout, real quick on the stats here. I forgot about that one. As you can see, I've got our 5 years of data from our Hep B program volume. The blue bars represent the number of perinatal hepatitis B positive women that we're case managing. And then the yellow line indicates I think the graph got shifted a little bit. The line got shifted a little bit. But the percentage indicates how many of those women received the appropriate post-exposure prophylaxis at delivery. Next slide. So because of our state's large layout and the many people involved in the program as outlined by the map and our populations, we need to focus on education with our enrolled mothers first. That's what we can really control, is speaking with our moms. We focus our educational interventions in a way that will help the birthing facilities better manage that birth dose administration. As mentioned by Dr. Hagemeyer yesterday, the birthing facilities can be extremely busy and lack the time to provide the education during a very eventful shift or during a very complicated delivery. And we want our enrolled moms at delivery to understand exactly what's going to happen when they have their baby to prevent hepatitis B and to be fully invested in that process of administering that birth dose and the immunoglobulin because she wants to keep her infant healthy. But not all of our field staff are clinical. We hold monthly meetings and then intermittent check-ins to assist them with their case management. But all of our regional coordinators are nurses. And we have nurses at our central office staff that can step in to lend another hand to have conversations with moms or dads about the Hep B care. As mentioned before, nursing staff always is available to step in to do more counseling, and we are developing materials that will give parents the tools to better communicate with their different care providers. And sometimes there's many different people involved in the pregnancy, the delivery, and the childcare afterwards. So what we're looking to design, and we have some designs already, is a postcard for mom to bring to her obstetrician to advocate for the appropriate testing and treatment in the prenatal period, including the DNA level checks and antiviral treatment, and then to bring a note to her delivery facility to inform them of the prenatal hepatitis B labs that have been done and the treatment she has received during pregnancy, and then another card to bring to her pediatrician after delivery to inform them of the baby's exposure at birth and the appropriate care and blood testing after. And then we want our care to be family centered. You know, if our mom, and this is, getting into some community organizing and other of the softer subjects, but if mother prefers to chat via the text, we do that. If the father of the baby is involved as well, bring them in. If the mom prefers that we talk to grandmother about what the vaccines are needed, educate grandmother. So we're doing constant education to all of the members of the household and helping them to get linkage to care where needed. Next slide. So teach the clinicians. As part of our program evaluation, our grantees are required to provide a quarterly education piece to some participant in the program in their respective area, such as a pediatrician's office, a delivery facility. And with that size across the state that we mentioned and the number of cases spread out over all of that space, you can imagine that someone may not see a case of perinatal hepatitis B but once every 10 years. And so they need a refresher, right? It's not something that happens all the time, so you're less likely to be up to date and up to speed. But with our 46 local health departments, 5 regional coordinators, and central office staff, we add up to about at least 200 acts of educational outreach per year across the state. And the opportunities are abundant. We have enough field people to provide the in-person visits with materials. And some areas even have, they have their own funding. They have their own funding to use the funding in the way that they want. So some areas have decided to focus on field nurses that provide education on a variety of topics, including perinatal hepatitis B. The nurses and the clinical staff in the facilities with the pediatricians and the obstetricians are sometimes the one running the office, right? So let's work with them to provide education, to offer continuing education, to provide the materials so that they can let their providers know about what's supposed to happen. We have provided different educational content for different specialties. So for an OB, we try to keep up with the current research, current articles. For the pediatricians, for the infectious disease and hepatologists, to keep them in the loop. And again, we want to reach out to hepatologists and infectious disease providers and practices that have a high concentration of clients with hepatitis B, especially women of childbearing ages, so that they can start that preconception education for women that are planning families so that they know what's going to be happening. And they don't have to rely on the time when they're having a baby to learn about what's going to happen after delivery. And then extra attention to those clinicians that take care of a large amount of our patients. For two examples, Vietnamese speaking physicians in the Houston or Dallas area, or providers in the free or the federally qualified healthcare systems. And finally, let's reach out to our midwives. Some birthing centers in Texas don't offer any vaccines. And just in the last 6 months, we've had 2 interactions with practices taking care of a Hep B mom. And we were able to provide them with the Hep B vaccines and the immunoglobulin at no cost. But that relationship with the midwifery office and the midwives within the practice may lead them to think, about at least offering and having on hand that birth dose of Hep B for all of their delivering mothers in the future. Next slide, please. Finally, we want to reach out to the hospital staff. We have over 200 birthing facilities all across the state. And in some locations, it's the labor and delivery person that types in and reports. Sometimes it's the newborn nursery, sometimes the infection control, usually it's the infection control department, but we have some very small facilities as well that don't have a lot of specialized positions in the facility. So we are working to have a very good contact at every single birthing facility so that questions can be answered and timely reporting can be completed and education can be provided. The Women's Health Service Directors have that authority to step in when there's bigger changes such as practice change, reporting change. We can assist them with developing standing delegation orders or policies that allow for the better birth dose coverage. And we also want to know our lab managers, because some of our rural facilities send out tests with a very slow turnaround, or there's questions about what happened with some indeterminate test results. So having at least one good contact at each facility can be a big support to making sure babies get the treatment they need at birth. Next slide, please. And finally, some other educational opportunities. We have a lot of military bases in Texas, and a lot of them are staffed with their own public health nurses, and making contact with them, detention facility staff, and connecting with the healthcare support within those facilities, and then groups that focus on the hepatitis B education in their specific communities. Next slide, please. And that's it. Thank you so much. And turning it back over to Lisa.
Yes, thank you so much, Melissa, for sharing all the great work that you are doing in Texas to protect babies from perinatal Hep B infection. I think we will move on now to our next speaker. And again, we encourage you to post your questions in the Q&A chat as we go. So our next speaker is Dr. Stephanie Deal. She's an associate professor of pediatrics and works at several hospitals, I believe, but one of them is the Baylor College of Medicine. And I will turn it over to you, Stephanie. Thank you.
Good morning. Thanks for that introduction. My name is Stephanie Deal. I'm an associate professor of pediatrics and a newborn hospitalist at Baylor College of Medicine in Houston, Texas. I'm honored to have the opportunity to speak to you today about my personal experience with 2 different approaches to the birth dose of hepatitis B vaccine at 2 different hospitals. So next. I have nothing to disclose. Next. So hepatitis B vaccine has been recommended for all infants since 1991 and recommended in the first 24 hours of life for infants greater than 2 kilos since 2016. This is because 90% of infants who get infected with hepatitis B go on to develop chronic hepatitis B, which can lead to cirrhosis, cancer, and early death. In contrast, the hepatitis B vaccine is very effective at preventing infection and has an excellent safety profile with minimal side effects. Next. So if the hepatitis B vaccine is safe, effective, and highly recommended by professional societies, then why is it declined by families? So the literature on hesitancy regarding the birth dose of hepatitis B vaccine shows that most families who decline the vaccination are either uncomfortable with the vaccine or with vaccines in general, or have a preference to wait until later to receive it. This closely tracks with what I have found in my personal experience as well. Next. So now let me tell you a little bit more about my personal experience with the birth dose of hepatitis B vaccine. For the last 12 years, I've worked at two very different hospitals within our system. Hospital 1 is a large public safety net hospital. There are currently about 3,000 deliveries per year. And in 2024, there were 2,936 deliveries of infants greater than 2 kilos, and they're therefore eligible for that birth dose of hepatitis B vaccine within the first 24 hours. The majority of patients are on or eligible for public insurance and have a preferred language that is not English. The newborn service is primarily run by pediatric residents under the supervision of attending newborn hospitalists in my group. Hospital 2 is part of a large private tertiary care children's hospital. There are currently about 6,000 deliveries per year at this hospital, and in 2024, there were 5,961 deliveries of infants greater than 2 kilos. The payer mix for the hospital overall is pretty evenly split between public and private insurance, and the preferred language for the majority of patients who deliver here is English. The newborn service is primarily run by attending newborn hospitalists with some limited pediatric resident coverage, and also there's a subset of patients who are cared for by their own private pediatricians within the hospital. Next. The approach at each of these hospitals takes towards the birth dose of hepatitis B vaccine is very different, though. At Hospital 1, the approach to the hepatitis B vaccine is more of an opt-out model, where the order for the vaccine is included in the delegated newborn admission order set, and the vaccine is given by the nurse when the family arrives on the postpartum unit once the parents sign the vaccine consent form, which is required by the state of Texas. The vaccine is usually administered within about 12 hours of birth and often clustered with the newborn bath. If the birth parent is noted to be hepatitis B positive, though, the bath and vaccine are administered more promptly. The approach at Hospital 2 is different and more of an opt-in model. This is because the hospital's legal department has decided it is required for physicians to obtain consent for any vaccine. Therefore, the order for the hepatitis B vaccine is not included in the delegated newborn admission order set and must be entered separately by the baby's physician after the verbal consent is obtained from the family. This is done during daytime hours within 24 hours of delivery. The only exception is for infants of a hepatitis B positive birth parent, in which case the orders are placed as soon as the pediatrician is notified by the nurse, and this is with or without a discussion with the family because it's considered treatment. The nurse gives the vaccine shortly after the order is placed, whenever that is, and the parent signs a consent form right before it's administered. Next, please. The uptake of the birth dose of hepatitis B vaccine in infants greater than 2 kilos at these hospitals is really significantly different. At Hospital 1, 99.6% of our infants over 2 kilos receive that birth dose of hepatitis B vaccine, while 88.3%, still pretty good, but lower, of those at Hospital 2 receive it. Of note, the rate of hepatitis B positive patients is pretty low at both hospitals. You can see it below. But it is higher at Hospital 1. We do have a more international population there as well. Of note, I have never seen a parent with chronic hepatitis B ever decline the vaccine or immunoglobulin for their infant at either institution. This is probably because they personally know the actual risk of hepatitis B infection. Interestingly, the statistics for who declines the vaccine are similar at both hospitals. The parents of infants who decline hepatitis B vaccine are more likely to self-identify as white and non-Hispanic, which is also the more prevalent demographic at Hospital 2. Next, please. When compared with vitamin K and erythromycin I prophylaxis, hepatitis B vaccine was the most likely prophylactic medication to be declined at both hospitals in 2024. Because the uptake of all three was really very high at Hospital 1, there's very little difference between them. The differences are more pronounced at Hospital 2, where declining routine newborn care interventions is more common overall. But the uptake of hepatitis B vaccine was much lower than erythromycin and vitamin K. Next. So I have noticed that there are 4 main reasons that families describe for declining the birth dose of hepatitis B vaccine. And the approach I take with each family depends on the reason that they're declining. The most common reason I hear is that families want to delay getting the vaccine until a visit at their primary care doctor's office. Sometimes they'll explain this because they want to make sure all the records are together, but I'm not always convinced that this is the real reason, since many aren't swayed by my explanations of the multiple, really easy way for us to get the records to their doctor's office. I believe that some of the families who are just uncomfortable with vaccines overall also state this one as their reason to decline. The second most common reason I hear from families is that it's not necessary, either because I'm negative and by Texas state law, moms have that testing at delivery, which is really nice, or that's an STD. For these families, I highlight that there are non-sexual ways of transmission and talk about the real risks of hepatitis B infection to their infants and young children using really plain language, like with words like cancer, liver failure, early death, to really highlight those risks. The last 2 reasons I see are almost never really explicitly stated by the families, but I really infer them based on the family's overall behavior. For some families, declining seems to be part of a pattern of asserting control over their birth experience. This is especially true for families that come in with this extensive birth plan and their birth didn't go to that plan. If I suspect this is the reason that they're declining, I make sure to emphasize that the family is really the ultimate decision maker here, giving them control, saying things like, this is your baby and your decision. But also, in addition, highlighting the risks of hepatitis B infection and the benefits of the vaccine and how safe and effective it is. For some families, though, declining hepatitis B vaccine seems to be a part of an overall distrust of vaccines, healthcare providers, big pharma, government, all of it. These families are the most difficult to persuade, and often they're less receptive to a discussion at all, and often are declining more than just the hepatitis B vaccine. Next, please. While techniques to address hesitancy at an individual level like that are always necessary, there are a few process-based ways that are supported by the literature as well. While not specific to the birth dose of hepatitis B vaccine, studies show that using standing orders, like we do at Hospital 1, and providing accurate information about the risk of disease are both really effective ways to improve a vaccine uptake. Although population differences undoubtedly play a role here, I suspect that having the hepatitis B vaccine as part of our standing delegated order set for newborn admissions plays a large role in our high degree of uptake at Hospital 1. Next, please. So how do I go about combating hesitancy at Hospital 2 when I'm unable to change into an opt-out model, at least so far, based on the hospital's legal policy? I have found that the words I use to approach the discussion of hepatitis B vaccine can drastically affect the answers families give me. When I first started my career, I would ask, do you want the hepatitis B vaccine for your baby? Or are you okay with hepatitis B vaccine? I quickly realized that I was getting a lot of families who declined the vaccine. So I changed to, we're going to do all the routine things needed for your baby before you go home, like the hearing test and the jaundice screen. This includes the hepatitis B vaccine, unless you have a problem with that. So I have found that this approach has led to much less declining of the hepatitis B vaccine. Using this language makes it sound like the typical routine newborn care that it is, and not extra. I found that many mildly hesitant or kind of unsure families don't want anything extra, but are really fine with the routine recommended care. The families that are firmly against vaccines, though, definitely still tell me no with this approach. So it still gives that choice if needed. Next. Now, if a family is still hesitant, despite using this more opt-out language, first I have to gauge the family's receptivity to a discussion about hepatitis B vaccine. If the family's not open to a discussion, then I've found that pushing the issue only further erodes any trust we might have had. And sometimes it makes it even more likely they'll decline other routine recommended prophylaxis and screenings. But if they are receptive to a discussion, I first ask why they don't want it, really listen and actively listen to their concerns and respond to those specific concerns. I have also found that if a family is refusing erythromycin ointment, vitamin K, and hepatitis B vaccine, they often have that level of distrust in the medical system in general, and they're harder to convince in the short time that they're in my care as a hospitalist. It really is a delicate balance to advocate for recommended newborn care while still developing that trust. And it's important to know when to accept their decision to decline and allow for that continued advocacy for the vaccination to happen at the primary care doctor's office where they can build that trust over more time. Next, please. So overall, based on both the literature and my personal experience, I have 3 main recommendations for optimizing the birth dose of hepatitis B vaccine uptake. First, if possible, make the hepatitis B vaccine an opt-out process by placing it with the standing delegated newborn orders, grouping the signed consent form if that's required by your state with other general consent forms, kind of putting it all together as routine care. Next, really ensure any staff, providers, learners, residents, things like that, use normalizing language when talking about the vaccine so it doesn't sound extra. And then last, with hesitant families, make sure to acknowledge their concerns and address those specific concerns to help develop some trust. When the birth dose of hepatitis B vaccine is presented as part of normal and routine care, both in our hospital policies and in the language that our healthcare providers use, I've found that it results in the best possible uptake of that birth dose of hepatitis B vaccine. And that's it. Thank you. Any questions?
Thank you so much, Dr. Deal. That was a really helpful presentation, and I love hearing all the strategies and techniques that you're using to talk to parents and sort of meet them where they're at. It sounds like the structural, the structural opt-out is obviously probably the gold standard if you can get that, but then also just you're using that sort of presumptuous message of, here's what we're doing today, is really great. So thank you for sharing your tips. I will encourage folks to keep putting their questions in the Q&A, and hopefully we'll have some time at the end for some open Q&A. At this time, we're going to move to our next speaker. We have Roberta Butler. She is the perinatal hepatitis B coordinator in Kentucky's immunization program, and I'll turn it over to you, Roberta. Thank you.
Hello. Thank you so much for inviting me to speak today. I listening to the others, there a lot of what they have said is I have similar experiences with. So, I think it kind of sounds like a lot of the challenges that we see are very similar. So, I have been with the Department of Public Health as the perinatal hepatitis B coordinator for almost 2 years now. So we'll kick this off. Go on, change it. Next. Okay, so Kentucky law mandates that all pregnant women are screened for hepatitis B surface antigen during every pregnancy. For those with positive results, they are required to report that to the county of residence that the mother lives in and to the Department of Public Health within 1 day. High-risk mamas who tested hepatitis B negative and mothers of unknown statuses, though, they must be tested at time of admission to the hospital for delivery. Next. Kentucky, just looking at it across the state, 46% of Kentucky counties are categorized as maternity care deserts. That's higher than the national average of 33%. As a young mother, I can relate to this because my birthing hospital was over an hour away. And because it was so far, um, at that time, the county health department, the provider would come and see patients there. So but that was still a 30-minute drive to get to that health department to be able to be seen. So, it is challenging. 72 of the 120 counties in Kentucky lack dedicated OBGYNs. 31% of women have no hospital within 30 minutes compared to the national average of 10%. And 14.3 of women who receive inadequate prenatal care, which leads with, but that is a little bit less than the national average of 14.8. Next. So some of the challenges that we have that I noticed when I come in was that we had limited providers that were reporting prior to delivery. We have limited access to the communication systems that caused outreach and educational gaps between the providers. Inconsistent identification of exposures before birth from the Department of Public Health, and there was no standardized process for access to hepatitis B lab results with pregnancy-related ICD-10 codes. And we needed stronger collaboration with the birthing hospital for timely reporting and intervention. Position changes in the state coordinators or the local health departments that presented some challenges to the program. Inconsistent case management training and communication and collaboration with those, the health departments that was a challenge. Another thing is the completion of the post-vaccine serology testing. You can get the parents to if we can get the series completed, it was just really hard to get this. It still is to get the PVST completed and collected. And then 58% of our families have language barriers. So that's very challenging. Now, I noticed that from January 1st of 2024 to March, that only 13% of exposures were reported by the OB providers. So, that early identification of the hepatitis B exposures, that's so important because you can start initiating case management, get to know the families, help walk them through and let them know what's expected and what it is, education. The local, we also had issues with not pulling labs from our NED system and the assessment of the ICD-10 codes associated with pregnancy. There was very limited established relationships with the birthing hospitals. One of the first things I did when I came into this position was to reach out to every birthing hospital. And I think I found 3 that had actually quit delivering babies. So I just wanted to get contact information and, and let them know who I was and what I was there for. So, that was one of the first things that I did. And then, like I said, we've had some issues with getting the PVST done. And some of the things that I've noticed is that, we could get, maybe the provider would order the hepatitis B surface antigen, but not the antibody. So, you have a hard enough time getting the parents in to get the test done, but then here they have to try to get them back in again for another stick. And that's really unfortunate. So there's a lot of, just trying to re-educate and trying to get the mommies to, if they understand the process, they're going to really, they want to advocate for their babies. So, it's just really important that I can get some early establishment with these moms so that we can really empower them to know what's happening and why we're doing this, and the importance of getting these done. Next. So talking about birth dose specifically, we reviewed EPID 399s from one birthing facility. And it showed that approximately 30% of the infants did not receive their vaccine at birth. Statewide, that raises up to about 50% that do not receive it at birth. Follow-up review with these infants did not receive the birth dose showed that 10%, a lot of them, we were finding that they were saying they wanted to wait until their first provider's visit. But when we went back and looked at it, 10% didn't get their vaccine their first 3 months, but also across the state, 10% of the infants did not receive it in their first year. So, it's really important, like some of the other girls said, to get them, really find out their reasoning for saying no in the hospital and really educating, because, if you have these mamas that have transportation issues, that, a lot of what we experience here, they're migrants. And so they're having, they have language barriers, they have transportation issues, or they may have multiple children. And so, trying to get to the doctors is a big deal because they don't have somebody to stay home with their other children while they go. And this language barrier is so big because, like, I noticed that some of our providers' offices do not draw labs. So they'll say, well, go down to the first floor. And to a mom that has a language barrier, that's overwhelming to have to try to maneuver through a clinic, go downstairs. And they might not be able to read those signs to get to the lab. And so, one of the things that I've really been working on is saying, if you don't, I always ask, the first thing is, do you draw labs in your office? And if they say no, we send them down the street or we send them downstairs. I'm like, if they're just going downstairs, please send somebody to go with them, escort them down there, make it easier for them to be able to get to that location and tell them what needs to happen, so that because that language barrier, it's just overwhelming to a mama. And it's overwhelming, especially if she has other children with her, to round them all up and try to figure that out. It's just, let's make it as easy as we can to make this go as smoothly as possible. In a review of a preliminary 2024 data shows, though, that 67% of infants born in Kentucky does receive their hepatitis B vaccine. Next, please. So in review, the majority of these that declined is they want to wait for their first visit with the provider. So you can see the different responses here that they said. And next, please. Okay, so our goal is to we need to take our 50% to 90% in order to meet our Healthy People 2030 target, and to ensure that our babies, our little Kentuckians, are protected. So we found two groups that, the majority of them, it wasn't the anti-vaxxers. They were the minority of the group. It was mainly they just want to wait. They don't see the need to have that first shot right at birth. Nobody wants to poke their baby, they're newborn. Some of the successes that we have had to try to make this easier is we've partnered with our MCOs to create a provider list for distributing educational materials and updates. We have developed hepatitis B toolkit, pamphlets, mandatory reporting letters to remind the providers that needs to be done. So I'm doing that in time. If I find out that mommy is positive and I did not hear from that provider, I'm sending that mandatory reporting letter straight to the provider to say, to re-educate, to let him know it's expected. And then we have lost to follow-up letters if we have those that we lose that we just cannot find. So we'll send that to the provider as well, letting him know if that patient shows back up, please make sure this is done. We're doing grand rounds, and additional trainings is in the development right now to go into our Kentucky train so that these providers can be, re-educated and continuing education. So through our enhanced case manager training and increased provider and parent education, our closure of exposures that completed the post serology testing increased by 33% from birth year 23 to 24. Next. We created reports to extract hepatitis B lab data for ICD-10 codes from NEDS. We've started quarterly meetings with the birthing hospitals to collaborate and educate on the hepatitis B care and expectations and educations and immunization hesitancy and just, how to educate and question. And we've also implemented quarterly meetings for the local health department case managers to improve coordination there. We developed a REDCap database for better documentation, and we provide on our meetings REDCap training for effective use. And so this has really, really helped, and I'm excited to see how this year progresses because our hepatitis B exposure identification before birth has increased from 42% to 68% with the REDCap. And has improved early intervention. Next. And that's it. Fast, sweet. Thank you. If anybody has any questions, just post them in the chat and I'll try to answer them.
Thank you so much, Roberta. I loved hearing about the challenges and the successes and the ways that you're really improving your program. And it's excellent that you're already seeing those results. So congratulations to you. And thank you for sharing. And like Roberta said, please keep posting your questions in the Q&A and we will get those either during the session or hopefully we'll have some time at the end. And then we're going to go ahead now to our next speaker, Dr. Malika Shah. She's the medical director of the newborn nursery at Northwestern, is it Medical Hospital, Dr. Shah?
Northwestern Medicine, yeah.
Thank you.
Yeah, of course. So thank you so much for the opportunity to present today. I am going to be taking a slightly different approach to this and kind of focusing more on the nursing perspective. I have nothing to disclose. As you all know, over 25,000 infants are born to mothers diagnosed with hepatitis B each year in the US. And we know that administration of the birth dose is highly effective, but that fewer than 75% of infants receive that dose in their first 3 days of life. Vaccine hesitancy and refusal have steadily increased over the last few decades. And a missed birth dose of hepatitis B is actually a risk factor for incomplete vaccination at both 18 and 24 months of age. So sort of delaying that trust in the medical system or what have you is actually a risk factor for additional diseases as well. To be honest, the challenges extend beyond vaccine hesitancies for many birthing hospitals. This is just a picture of Northwestern Medicine, the Prentice building, where there are over 10,000 deliveries every year. And one of the things that I just really wanted to point out is all the newborn tasks that just keep getting added. Yesterday, we had a really nice presentation where one of the presenters actually said that nobody had actually even talked about the hepatitis B vaccine in her entire stay with her newborn. And we wonder, right, why? And so here we have like our little welcome packet to the Prentice postpartum unit. And what we have are basically infant security that we need to talk about, infant feedings that we need to talk about, identifying help at home, a pediatrician visit within 24 hours, making sure that that's established, pain management in the mom that is not just one time, but that is done on a sort of a continuous basis every time that vital signs are checked, the hepatitis B vaccine, which we want before 24 hours, a bath, and also teaching the family how to give a bath, the metabolic and PKU screen, the congenital heart disease screen, a couple of infant weights, the hearing screen, which is now standard throughout the United States, a jaundice and bilirubin screen. We also have educational videos that we really want the parents to watch. We oftentimes offer a newborn photo shoot. If we don't have that happening, it probably is family members that are wanting to do that. Car seat and transportation safety. We actually have a very active safe sleep initiative going on in our unit right now. To educate every parent on sort of risk factors for SIDS. Folks will come in to do a birth certificate and Social Security. We need to recheck on that pediatrician follow-up appointment to make sure that it's been made. And oftentimes we have a discharge class as well that we request that families go to. So if you add all this up, you can see that it's going to be 10 hours or even more if you get into a longer discussion about any one of these topics. Well, meanwhile, the length of stay has really, really gone down in the United States. So in the 70s, a C-section, the average length of stay was kind of almost close to 8 days. And the length of stay for a routine vaginal delivery was close to 4 days. And now our C-sections are typically about 4 days. Oftentimes in our hospital, our goal is really just 3 nights. And our vaginal deliveries are, sort of between 2 and 3 days, no more than 2 nights. It actually, insurance doesn't even cover more than 2 nights unless there's a complication in the mom. So as you can imagine, in these really short hospital stays, it is becoming increasingly difficult for nurses to do everything that they're not only required to do, but also required to document. So with these newborn tasks that just keep getting added, what we did was we put a bunch of the tasks, all of the ones that are in green, and put them into what we call a 24-hour bundle. It's called a cluster care initiative, and it was developed by 2 nurses, Shannon Blair and Haley Gillespie, who I really want to give a shout out to. And it was initiated in 2020 to standardize care within the baby's first 24 hours. So basically, at 23 hours of life, we were going to immediately go in, give the Hep B vaccine, and that consent should already have been obtained, do the weight and bath, and then after 24 hours of life, which is sort of mandated by policy, we were going to do the congenital heart disease screen, the metabolic screen, and then in 2022, we actually added a jaundice screen to this as well. This, just so that you all know, is not for anybody whose mom was Hep B positive. Of course, that would occur much, much earlier. And then we researched it to see, is this even helping? Because so often we come up with these plans, we try to do something, and we really don't have any evidence that it's really actually helping anything. So we looked at whether the 24-hour baby bundle was effective at increasing rates of hepatitis B vaccination within the first 24 hours, whether it was more effective at delivering cluster care for specific patient populations. As Dr. Blair and others have pointed out, there are specific populations that do tend to decline vaccination more or delay it more. And then are there parent demographics in these that decline the hepatitis B vaccination for their infant? So our study design was 22,057 infants born at Northwestern Medicine. We had pre-intervention birth dates, which were from February 16th, 2019 to January 16th, 2020. We had a washout education period that was about 2 months. And then we looked at post-intervention birth dates from March 17th to February 16th, 2021. And we really did see some notable changes. So our 24-hour baby bundle was implemented in February of 2020. And prior to that time, we had probably around, it varied from month to month, but about a I think it was a 43 or 46% vaccination by 26 hours. And by 24, after in our post-intervention period, it significantly went up to over 60%. So you can see here that within 24 hours, it increased significantly from 43% to 60, almost 67%. And our hepatitis B immunization prior to discharge significantly increased as well. Now, we were at a very high rate already, 98.18% versus was pre, and then post was 98.82, but that was also statistically significant. Our intervention outcomes by maternal race really were very were positive across the board. So for white, Caucasian, Asian, Black or African American, Native American, Native Hawaiian or Pacific Islander, or multiracial, they were all statistically significant. And we did also look at the parents who refused vaccination. We did find that those who refused, to Dr. Blair's point, when it's just presented as routine standard of care, it did decrease after the 24-hour baby bundle. It's from 1.82% to 1.08%. I know that seems really small, but when you have a population of 10,000, that's actually quite a few babies. We did find that those who refused vaccination were more likely to be multiparous, 64% versus 52%, were less likely to use formula during their admission, and were far, far more likely to decline vitamin K, almost to the magnitude of, an odds ratio, I think, of over 20. So those who declined vitamin K were also very, very likely to declare hepatitis B. So where do we go from here? Well, what we know is that implementation of a 24-hour baby bundle improves time to vaccination, overall vaccination rates in our large hospital, and that it's effective across all patient demographics. What we need to study is whether this intervention is successful within other communities, specifically those with lower baseline newborn vaccination rates. It sounds like Kentucky's doing a really, really good job at moving this forward. I don't know if there's other populations, and certainly across the world as well, if there are opportunities there. We weren't able to analyze the impact of bundling care on cost savings and staff satisfaction in the newborn nursery. We were able to look a little bit at length of stay, and it didn't really cause a huge difference. But again, we're very much under the gun to get our babies out very quickly, to get our mamas out very quickly as well. So we had kind of already done a lot of work on that. I wasn't terribly surprised that this didn't make it that much different. It did really help with babies that are either transferred from the NICU or have a lot of other issues going on, to just sort of have that 24-hour mark as a time when to make sure that all of these things are done, almost like a set point. And what we can do today, I'm bundling care in sort of the adult ICUs in many other aspects of medicine has really been shown to increase compliance. And our bundling care definitely reduced periods of separation between infants and families. We need to continue to emphasize the importance of timely administration of the Hep B birth dose vaccination in preventing infection. I really want to highlight what was said yesterday. It can be really too late, I think, and a huge burden on nurses to start that in the postpartum period. It probably makes a lot of sense to talk to OBs, to talk to moms beforehand, so that when this happens, it isn't a surprise. And then obviously continue to educate patients on the importance of vaccine compliance for newborn health, meaning keeping on the schedule so that babies are completely caught up. And that is all I have. I have some references if folks are interested. And I really want to acknowledge the medical student who's now graduated and is in her OB residency right now in Pittsburgh, the nurses who came up with this, and the coalition for inviting me to speak. Thank you.
Thank you so much, Dr. Shaw. That was really great information and things that are very practical that hopefully other delivery hospitals can implement to try to increase their universal birth dose coverage. So I really appreciate all of the practical information that all of our speakers have shared today. And the presentations, I believe, will be available on the CGHU website after the call. And Melissa DeHaan from Texas also said that once they finalize that prenatal care postcard, that we could also post that as an additional resource on the site. I know there was a lot of interest in that postcard and the question and answers. So it looks like if we're at the top of the hour, I know people probably need to sign off, but there is one last question. If you would like to address that, Dr. Shaw. Could these cluster care initiatives be done for home births as well? What would be the challenges with this?
Yeah, I absolutely think that cluster care initiatives should be done for home births as well. I think it's really interesting how hospitals just view everything with like sort of day of life. They want people going home, at least in Illinois, after 2 nights of a hospital stay with no regard for what time in the day that baby was born. So you could have one baby get to stay, literally almost 72 hours for a vaginal delivery, and another baby barely get to stay more than 30 hours. I think a home birth situation, it's not going to be looked at like that, but a lot of our weight loss curves, like the new weight loss curves, are based on hour of life. Our bilirubin curves are based on hour of life. All of these things are based on hour of life. So I'm not very familiar with home births, but for those who are, it seems like if they are doing the screening with a transcutaneous bilirubin meter, with a pulse oximeter, and weighing the baby, I don't see why that couldn't be done in the same way. But I don't know if these are birthing centers or if these are truly just at home with a midwife and what it is that she has available to her. But I'm happy to stay for a minute or two with that particular person if they want to share what, I just don't know what the midwives have available to them. But I don't see any issues with doing this in a home birth environment.
Thank you so much, Dr. Shaw. And thanks again to all the participants and again to our wonderful speakers. We really appreciate you joining today to hear about this important topic. And Lindsay, can I turn it over to you?
Great. I think we'll end it there. Thanks so much, everyone, for joining. Please
Thank you.
sign up for the Coalition newsletter for more information, and we'll see you next time.
Thanks.
Thank you.